Hello and welcome to our presentation on the Varicella-Zoster virus. Today we will be looking at the history of the virus and making compare and contrast between chickenpox and shingles by looking at the environments they thrive in, epidemiology, and treatment and prevention. The first discovery of chickenpox was made in the mid 1700s, while the first shingles discovery and the hypothesis about what exactly it was made in 1831, while the confirmation about what shingles was made in 1861, with the connection between the two being made in 1954. Now, the first vaccine against varicella popped up in Japan and Korea in 1988, with the first vaccine made exclusively for chickenpox in the US being made around March of 1995. Proquel was licensed in the US in September of 2005, and the herpes zoster vaccine that was made for the prevention of the shingles virus was made in May of 2006.
So now I'm going to talk about some of the characteristics of the chickenpox. It's an infection caused by the Varicella-Zoster virus. It's a skin infection that forms spots of blisters across the skin, as you can see on the right side of our slide. It first appears on the chest, back, face, and then it spreads across the body. It's highly contagious, mainly affects young children, and it's very serious in infants under 12 months of age. Some characteristics of the shingles are it's a reactivation of the virus. Its latency is stored in the neurons. It comes back in the form of extremely painful blisters on only one side of the body, and is usually in bands either on the torso, shoulders, neck, or face, and it mainly affects adults over the age of 50. This is just a comparison between both diseases, and some acute complications of the chickenpox are bacterial sepsis, pneumonia, encephalitis, and some acute complications of the shingles are meningoencephalitis, myelitis, cranial nerve palsies, vasculopathy, and gastrointestinal ulcers, pancreatitis, and hepatitis. Comparison of transmission for the chickenpox. A person with this disease is contagious 1 to 2 days before rash onset and remains contagious until the rash has crusted and dried. And for the shingles, the disease can only be spread in the blister phase. For the chickenpox, once you have been in contact with someone that has either the chickenpox or shingles, it takes about 2 weeks for someone to develop the chickenpox. And getting the Varicella-Zoster virus from someone with the shingles is less likely than from someone with chickenpox. If the shingles rash is covered, the chance of transmission is very, very low. And if the virus is transmitted, the infected person will get chickenpox. And it can also be transferred or transmitted vertically from the mom to the baby.
Now, do we know where we can find the zoster virus? That is correct. It is worldwide. There were incidents found everywhere in the world, and because of that, it has a plethora of names. I am not going to say what those names are because I don't know the correct pronunciation of them, but in Spanish, we learned that Dr. I said in Spanish it says it means it's called culebria, or I think that's what she said, and that means that's loosely translated to small snake. In Norwegian, the translation means hellfire, and then in Arabic, the translation is belt of fire. The next slide is what we see here, and that is the varicella incidence per 100,000 population in just 4 states. And that those states are Illinois, Michigan, Texas, and West Virginia. As you can see, in 1990, there were over 4 million incidences recorded. And in 1995, we can see that the vaccination had started to happen and a huge decline in incidences recorded until we get to the 2-dose vaccination. And then It's almost down to nothing, almost nothing in 2014. It's very interesting.
So some epidemiology. Humans are indeed the reservoir for the zoster virus. The occurrence is mainly in children. As John said, its prevalence and incidence is worldwide. In the past, it was estimated that 500,000 to 1 million new cases were occurred in the U.S. This was an old study. Now it's very low. Interesting tidbit, tropical locations have a higher, on average, have a higher percent of adults infected rather than children. Now, incidence, in healthy individuals, there's about a 32% chance of a lifetime risk of the zoster virus. This is worldwide. There is about a 50% chance of the older population, that is older than 85, will develop chickenpox or shingles. That also includes the immunocompromised. Peaks of incidence for the zoster virus are very seasonal, as studies have shown. There are peaks for more temperate climates in the late spring, and then in the driest and coldest months for more tropical climates. For the burden of disease, it is definitely age-specific. Incidence is definitely in younger children. These children, as Marina said, are of daycare age or in groups like schools. The reoccurrence of shingles in the adult population is much higher in areas without proper medical care. Most data is limited due to the studies being done in more developed countries, and because of this, the estimated burden of the Varicella-Zoster virus is much larger. So this study shows the minimum burden of the disease. Some risk factors affecting the severity of the disease will also increase this burden. Cases like infants and pregnant women, if there is immunocompromised in these populations, and populations without access to proper treatment and vaccines. Now, the vaccine is almost 100% effective today. It is cost effective and helps decrease this burden. There's not many children today get the chickenpox.
Now for treatment and prevention. It's very similar for both the chickenpox and the shingles. For the chickenpox, it is preventable by vaccine and is usually recommended by doctors for children around the age of 12 months and between 12 months and 12 years, and it is treated with antivirals, while the shingles is also prevented by vaccine and is usually recommended by age 50 and can also be treated with antivirals.
The end.